Podcast. See what's on your mind. It's the Treatable Podcast. Real, coming, treatable. The Treatable Podcast. It's all on the Treatable Podcast.
Trauma has become a buzzword in mental health circles, often overused and misunderstood. But what does trauma really mean? And how does it play a role in our lives? Why does trauma so often lead to addiction to substances? And can people really overcome trauma in their lives? Or is it a wound that we carry with us forever? Welcome to Treatable, the podcast that explores mental health challenges with experts who show us that change is possible. I'm your host, Clint Mally, and today we're doing a deep dive into the concept of trauma, a diagnosis so vast it's going to take 2 episodes to explore. In part 1, we're going to learn what trauma really is, and then in part 2, we'll look at effective treatments. Joining us today is Dr. Michael Barnes, a renowned trauma and addiction expert with over 40 years of experience. He's the founder of the Michael Barnes Family Institute and author of When the Solution Becomes the Problem, a book exploring the complex intersection of addiction, trauma, and family dynamics. Dr. Barnes has a unique perspective, having personally experienced the devastating effects of family trauma when his young son was severely injured. And today, he'll share his insights on secondary trauma, family resilience, and the path to healing.
Treatable Podcast. It's all on the Treatable Podcast.
Dr. Barnes, thank you so much for joining us on the podcast today.
Yeah, thank you. Thanks for the invitation.
So, trauma, maybe the most important underlying thing at the root of mental health and addiction problems. When you think about trauma and when you're trying to explain trauma to people, where do you start?
Well, typically, when I ask people, they tend to think that the event is the trauma, and that the real trauma is our biological response to that event, and that keeps us so stuck in our responses. And so there's been so much research on the neuroscience associated with it. And it's important to recognize that not everyone who has a trauma, an experience of what we might consider a traumatic event, experiences post-traumatic stress disorder. I mean, resilience is a key issue. Family history is a key issue. There are so many, we were just talking, it's more complicated than people think. So often people think, well, if I just tell the story enough times, that it'll just go away. And that's just really not the case. The term post-traumatic stress disorder wasn't identified until 1980. And so often we really saw it as an emotional problem. It's a problem of psychological, but it's really a biological and psychological and social issue. And my personal opinion is that we kind of have trauma conceptualized wrong, and that we have this sort of linear belief that an event happens, someone experiences it, they have symptoms, and then they go to therapy and either resolve them or don't. And I don't think that's how it works. I think an event happens, person experiences it. Everyone who loves them is also impacted, and that it is that recursive interaction between the individual and the people who love them that will often help to maintain some of those trauma symptoms. And so often I've heard individuals who are the primary trauma survivors say, I really can't talk about my struggles with my family because it just makes them so much more upset, or they feel so much more powerless that they weren't able to do something to prevent this. And so I try to make it a habit when I'm talking to individual therapists who do trauma work to ask them, do you talk to your client about how their family is reacting to all of this? And so often they look at me like, well, what's that have to do with it? It's their trauma. And it's like, well, it kind of has everything to do with it. And that recursive responsibility, that recursive, I always use a mobile over a baby's crib, that as one person is impacted, the rest of it doesn't just stay still. It's all moving and adjusting to try to create a new normal, a new homeostasis. And in addiction, that's a huge part of, as families begin to struggle with symptoms that are experienced by family members as being traumatic. overdoses, trips to the hospital. Interestingly enough, I did a research project where I asked families, what are the things about addiction that are the most traumatizing? And the one that almost everyone said was the sort of shattering of dreams, the idea that like this isn't how I envisioned our family to be. Like it's a grief response, it's a response of loss that is so much part of it. And I think grief is the piece that is often left out. We don't talk about, well, what did you lose in this experience? And it might be freedom. It might be a naivete that allows me to go into the world, freely and, openly, that now I'm cautious and hypervigilant and those kinds of things. So the event itself is the impetus. The nervous system is the trauma, is the biology that causes us to behave the way we do.
So it's not just, I've heard it said and described, it's not just what happened to you, but it's what happened inside you as a result, right? So it's not just the event, but what's gone on inside of you as a result. There's a few things that you said that really stood out to me. When we think about PTSD, people think about PTSD as being this diagnosis that's been around forever, but it's actually a relatively new diagnosis. It wasn't until soldiers were coming home from Vietnam that the formalization of PTSD became a part of the DSM, right? The Diagnostic Statistical Manual of how we diagnose folks, right? So PTSD is relatively new, and the idea and the understanding of trauma has been evolving ever since. World War I, World War II, not a thing. PTSD didn't exist. You just were shell shocked. That was the common term that people used. But with soldiers coming home from Vietnam, it was completely different. And you brought up a really interesting point, is that not everybody who goes through an experience, even a traumatic experience by the definition that we would maybe associate of war or challenging time, comes home with PTSD. And what you're saying is that a lot of it has to do with the interactions with the family, with how they were raised, with the connections and relationships that they had before the event happened. So I was wondering, I wanted to make this episode kind of a starting place for somebody's understanding of trauma. So I was hoping you could do two things. One, unpack the difference between big T trauma and little t trauma, and the difference between chronic and acute trauma in like simple everyday words. And then we're going to dive into the whole family relationship, family dynamic, the underlying why behind how trauma starts. Is that okay?
Sure.
So what is big T trauma? What is little t trauma?
It's interesting that those were very popular terms, and I try not to use those terms because it implies that one is less severe than the other. And so big T trauma and like a single event, what we would call like a shock trauma, something happens that is unexpected outside of our normal experience that is potentially life-threatening, those kinds of things. And so that it is such a shock to the nervous system that there's really no way to prepare for it. So that's what we would typically call post-traumatic stress disorder, those big T shock events. So small T trauma is what we would call either developmental trauma or complex trauma. Those are more traumas associated with not getting one's needs met, taking care of other people, being like ACEs, adverse childhood events, physical, sexual, emotional abuse, neglect, living in a family where there's a lot of arguing, where there's domestic violence, addiction, mental health, those kinds of things. But the bottom line is that there's, in most cases, growing up in those families, there's a more of an anxious or even an avoidant attachment, a lack of connecting to people, tending to be more reactive. So some of the symptoms you might see, like they get their feelings hurt really easy. They don't feel like they fit anywhere. They're really good in crises, but they're not very good at planning, because why would you plan? You never know what's going to happen in this family. That they do what people want them to do. They be who people want them to be, and then grow up and realize, I have no idea who I am. And so I personally think post-traumatic stress disorder, the big T event, is easier to treat than the developmental trauma.
This is really interesting because I think that there's a feeling in the general population that people who have experienced developmental trauma or complex PTSD should just be able to get over it, more so than someone who's experienced a single shocking traumatic event. So can you explain why complex PTSD or developmental trauma is more difficult to treat than just PTSD?
With PTSD, one of the early questions is, can you remember a time when you felt safe? And most people will say, "Oh yeah, when I was a kid, I was safe. Before the car accident, I was safe." So they have a frame of reference to begin to recognize, well, I know what that felt like. So as we're going forward, we can begin to reflect back and forth between us. But for someone who grew up in a family with severe addiction, or someone who grew up in a family with mental health issues or trauma, when I say to them, do you remember times that you felt safe? It's like, have you been listening to what I've been saying? No, I've never felt safe.
So what is the difference then in approaches to treatment for PTSD versus treatment for developmental or complex PTSD?
One is rehabilitation and one is habilitation. And rehabilitation basically is about, you've developed those skills at one time. Now let's help you work through the biological shift. Let's help you get reconnected with the story and how it actually happened. And then socialization and back into the community. With developmental trauma, if I didn't develop a healthy, secure attachment and I didn't learn that people were safe, then those are skills that we have to teach people. And your treatment center works with these young adults that I think are sort of really important in that habilitation piece. This happens a lot where you'll have a 25-year-old who gets sober. They've been using since they were 12 or 13. There's trauma in the family. There's always some issue in there. And they get sober and they don't have to do anything. Like they're like emotionally kind of lost. They're directionally lost. I had a 38-year-old call me after a presentation and he said, "I'm 38. I've never paid my own bills. I've never bought a car. I've never been able to maintain a job because of my addiction. Every time I get sober, I relapse because of my shame at not being able to do the things that people expect me to do." And sometimes parents will call and say, he's 25 and he's sober and I'm grateful, but he sounds like he's 15. Like he talks like a teenager. And it's like, well, he emotionally and developmentally might be a teenager. And so that's where developmental trauma often comes in, that they have been using very early as a self-medication process. And the stuff that other kids were developing in school and learning how to kind of feel their feelings and have opinions and connect with themselves doesn't often, not often.
This episode of Treatable is brought to you by Sandstone Care, which helps teens, young adults, and their families overcome challenges with mental health, substance use, and addiction. They provide age-specific, individualized treatment plans centered around your unique situation and goals, and they only use evidence-based therapies to help you get there. They keep their group therapy sizes small so folks can connect with others going through the same struggle and so that you never feel alone. They also give academic and vocational support to help you improve your grades or to get started on your career path. And lastly, because they know that mental health and substance use affect the people closest to us, they provide support for the whole family through their family therapy program. To learn more about teen and young adult treatment options, go to sandstonecare.com. Change is possible, and Sandstone Care is here to help. Let's break down this developmental trauma situation because, to your point, 10 people go to war in Vietnam. They experience a traumatic event together. 10 people come back, hopefully. A few of them have PTSD, but not all of them. And a big component at least from the research that I've read about PTSD, long-term effects, being able to bounce back after a really traumatic situation has to do with, as you mentioned, an underlying feeling of safety. So when we think about Maslow's hierarchy of needs, we have food and shelter and water and all of those things and clothing, but also right at the bottom, at the foundation, is safety. If I don't feel safe, it is hard for me to do any type of emotional growth, any type of social growth. If you don't feel safe, very little else is possible because you're constantly worrying about survival. I was hoping that you could break down what researchers and what trauma experts talk about as the attachment styles. And styles is kind of a terrible way to talk about it, because when we think about styles, it sounds like the love languages, right? Like words of affirmation and gifts and things. It's not really like that. It's not just like how you choose to connect with people because it's you're pessimistic or optimistic, or you're an introvert and extrovert. It's actually based upon the relationship with your parents. So could you walk us through the different attachment styles that someone might have as a kid and how that impacts their relationship and growth emotionally and socially in regards with trauma?
So it's important to understand that my belief is that attachment happens when the big people in my life co-regulate their nervous systems while teaching me how to regulate mine.
Could you break down that co-regulate and regulate just for our listeners who are not familiar with that terminology?
So the idea of when a child is in distress, they cry. They put out a message that says, "Hey, I'm over here. I need you to change what you're doing and come and take care of me." And for families that are able to do that in a healthy way, that by coming to that child and picking them up and talking baby talk and changing them, and just the body to body kind of connection allows a child whose nervous system is dysregulated, meaning they are upset, they're in need, and that is regulated by these adults who are really regulated, who are understanding what's going on, and they're loving and they're gentle and they're soothing, and that our attachment is based on, were we taught to co-regulate by people who could regulate.
So essentially, our attachment styles are closely related to our initial experiences with being taught to regulate our emotions.
So this is biological as well. And we have a nervous system called the polyvagal system. And the ventral vagus nerve wraps around the side of our face and goes to our heart. And it is it's the human system for connecting to other people. And so if I talk to you and you're pleasant, that nervous system will send messages that say, "Hey, we're safe. Let's down regulate, or let's turn off the fight or flight system, and let's just chill and have a good conversation. Let's relax." And the more, as children, we are kind of raised in those environments that are safe and that are regulated, and there's protection and conversation, and you're allowed to have your emotions, then we can begin a process of what we call upregulating, or turning on the social connection system, so that we develop what's called a secure attachment. And secure attachment basically means that I can feel my feelings. I can deal with distress. I can trust people. I can get my feelings hurt and manage it. And it doesn't mean that people are bad. So that's the healthy attachment. And then the next most common is an anxious attachment. And if my parents were inconsistent with how they responded to me, meaning sometimes they were pleasant and talking baby talk and doing those things, and other times it was, I'm in the middle of a Zoom call here, I don't have time for this, that the child begins to learn that I need to be prepared for both. And so they kind of down regulate that relational system and turn on the fight or flight system, the anxiety system that says, I need to make some decisions really fast to decide what to do, how to be, what to say, those kinds of things. And so that if they're upset, I'm going to act a certain way. If they're gentle and friendly, then I'm going to act a certain way. I don't necessarily trust people. I react to people. And so that would be an anxious attachment. And the third is what we call an avoidant attachment. An avoidant attachment basically says, man, this is a dangerous place. Even being what people want me to be doesn't feel very good. And so I don't need people. Like the anxious attachment person as an adult tends to be a people pleaser. They say yes when they mean no, and they say no when they mean yes, because they don't want to get in trouble. They don't want to hurt people's feelings. Anxious people with an avoidant attachment are generally really isolative. When they come into treatment, they tend to be the one that helps everyone else with their problems because they don't want to share their own problems. And they tend to be the one that everyone leans on. They look really good, but they don't connect to people. They don't trust that being themselves is safe enough to really benefit from treatment. And then the fourth and last kind is what we would call like a mixed attachment, which is some people kind of struggle in both ways. That they'll be anxious about people pleasing and sort of fitting in and doing and saying the right thing. But if they get their feelings hurt, they can pretty easily, people can be dead to them pretty easy. And so, there's always been the question of, can you grow out of that? Can you change that? And I personally believe you can. I think being really mindful of all of that is driven by the autonomic nervous system, by the fight or flight system or the avoidance or freeze system. And, the new therapies for trauma are not about telling the story. They're about learning how to regulate the nervous system. And so if we can help someone who has let's say an anxious attachment, begin to regulate that and calm that down and take risks, they can learn to trust people and connect. It's not easy, but they can do it.
Yeah, I want to summarize what you're saying for listeners, for watchers, just because it's so important and so foundational to what we do and to understanding how to overcome it. And I'm really glad that you said, hey, good news. I believe that you can actually overcome these, but we do need to unpack them and understand them and make sure that people get it. And basically, your ability to regulate your emotions is not a thing that anyone is born with. If you are good or you are bad at it, it's because you were either taught or not taught how to regulate. Regulating your emotions is something that is taught to us by our caretakers, by the adults within our lives, right? And the amount that you were taught as a child to be able to regulate your emotions in a variety of situations will determine the way that you connect with people or don't connect with people, the way you deal with challenging or stressful situations, and the means that you turn to be able to cope with those challenging situations. One of the things that stood out to me when you were talking about this is, yes, as a baby, when we cry, we need to get touch. We put our head next to the heartbeat of our mother. We feel their breathing pace and we are able to calm down. And we know that this kind of they call them mirroring neurons, right? Our brains connect with other people and they allow us to be able to look at their faces and see that they're happy so we can be happy, to hear their heartbeat and to sync our heartbeat, to feel their breathing and to change the pace of our breathing. And this is one of the reasons why equine therapy has been helpful for folks with trauma in the past, is because they are forced to be able to regulate with an animal. I used to spend hours, and I used to be a stunt performer and would do equine therapy type of situations, but I learned to ride as an adult, and I had to do a lot of complex stunt work where you're jumping off of horses and you're jousting on horses and all of these things. And as an adult, one of the things I realized is that the horse is assessing you from the moment you walk up to them. They're looking at your stance, they're looking at your face, They're feeling your heartbeat. They can feel the tension in your muscles as you squeeze them. And so one of the cool things about equine therapy is it forces you to be able to regulate your emotions, because if you're not calm, they definitely won't be calm. And it's a self-regulating mechanism. Now, equine therapy usually start on the ground. You're like petting the horse and you're talking to the horse and you're just trying not to get bit by the horse and those kinds of things. But the point is that we learn to regulate in the context of other people and our caretakers. And those needs for regulation, whether it's getting fed or held or changed as a baby, only become more complex as we get older. So maybe somebody says something to me and it hurts my feelings, or maybe I trip and I fall, or maybe I'm trying to open something and I can't. The needs change and get more complex as we get older. And the way that our parents, not just when we're infants, but also when we're infants, but as we're growing up through toddlerhood, through young adulthood, through teenage years, the way that we're taught to self-regulate impacts the way that we relate to others and self-regulate as adults. Is that right?
That's exactly right. And it's not like a parent can't have a bad day. There's a video that's on YouTube called the Still Face Experiment, and it was done at the Boston University. And it shows you how quickly a child recognizes a shift in parental mood. And it has this mom who's playing with this baby and doing all the things that moms do. And then the mom turns around and comes back around with this completely flat look. And within a second, the child, who's, probably 6 months, 7 months old, you just see their eyes get big and they look like, something's different. So the idea that we are kind of always assumed that kids didn't know. And one of the things that I wanted to say is that we are all born with the ability to connect, and we're all born with the ability to fight and flight, and we're all born with the ability to dissociate and to freeze. It's how those systems get trained that really allow us to have a secure attachment. And let me complicate this a little bit. And so there's a process called epigenetics. And the idea is that if, say, 2 or 3 generations ago, someone in your lineage had a pretty severe traumatic event, that these proteins can attach to the DNA and begin to interfere with how the DNA works. And so, unfortunately, it seems to happen a lot in our ability and the parts of our brain that regulate our emotions. And so the problem is those proteins can be passed from one generation to the next through the egg and through sperm. And so I could be a child who happens to have those proteins that may impair my ability to even make a connection to other people, because I can't self-soothe, and even co-regulation doesn't soothe me very well. And we've all kind of heard of those kids that just are pretty immune to just about any kind of nurturing. So that's a big area of study right now. How much of this is epigenetic?
Yeah, so like there's that term of generational trauma, the scars that we carry with us throughout the generations based upon the way that trauma is passed on, as we talked about, from this caretaker-child relationship and the way that they learn to self-regulate. Most parents are just doing the best job that they can. They're parenting the way that they were parented themselves. They're regulating the way that they themselves learn how to regulate. And as we mentioned earlier, that many people, hey, our world has been fraught with wars over and over and over again that have impacted people. And there hasn't always been, and most of the time there has not been, words to be able to describe the feelings that people are going through, therapies to be able to address and to process the trauma that they've experienced. And so people have to come up with their own ways to soothe themselves, to cope. And if those are good ways, those are positive coping mechanisms, then they get passed down. And if they're maladaptive or if they're bad, then those also get passed down. And so you said there's 4 different attachment styles, and I just want to make sure that our listeners, watchers get this. We've got the secure attachment style in which your parents, no parent is perfect, but your parents were there for you. They helped you regulate your emotions as you grew up. They were there for you. They tended to your needs, those kinds of things. The second one is an anxious attachment. This is where, sometimes they were there, sometimes they weren't there. And so you kind of had to be on your guard of which one was going to be. Then there's the avoidant, in which that avoidant comes through a parent or caretaker who's preoccupied and trying to just survive themselves. Are they depressed? Are they involved in addiction? Do they have some sort of underlying mental health condition that doesn't make their child the top priority in their situation because they're trying to cope with life themselves? And then you have the mixed, which is anxious and avoidant. It's kind of a combination of those two, right? So sometimes you might get the attention, but the attention might be negative or angry, right? And so you develop a combination of these two. And somebody who has an anxious attachment style, they might be the people pleaser. They're the ones who are constantly assessing who they're going to be, if they're getting the good or the bad parent, and that carries on into the relationship. If someone has the avoidant attachment style, they're the isolated. Sometimes I've seen that this has developed into like a narcissism, like it's me versus the world.
Yeah.
It's me versus everybody else. They're the rock. They're the people who try to help everybody, but have a hard time connecting with others or sharing their own feelings. Is that a pretty good summary of those attachment styles?
Yeah, that's good.
All right. So this next part is we're going to talk about some coping skills, coping styles, regulation things. And you talked about 3 different things that we are all born with. And I love how you laid this out. You said that all of us are born with being able to do these 3 things: to connect, to fight or flight, right? And to freeze or dissociate. And I was wondering if you could unpack, we get the connect. I think we understand fight or flight in our given world, but could you unpack freeze, but especially dissociate, and what that means and how we learn how to do that?
So fighting and flighting and freezing are all part of a continuum. And so there's a nervous system that we call the autonomic nervous system that is made up of two branches, if you will. One is the sympathetic nervous system, which is, it typically turns things on. Like when your kidneys need to filter the blood, this sympathetic nervous system activates it to do that based on set points and all this other stuff. And so when we ramp from being calm and relaxed to stressed, our heart rate changes, our biology changes. When we go from being stressed to highly stressed, which is kind of where we kind of are heading into either traumatic material or just a really horrible event, can be not traumatic, it can be really stressful. There's a point at which the sympathetic nervous system can no longer, we can't go any higher in the fight or flight. It's the problem isn't going away. And so once that happens, we hit what's called an overwhelm, and then the sympathetic nervous system turns off. Well, it doesn't actually turn off. It down regulates a little bit, calms down a little bit. And then what's called the parasympathetic nervous system, or the part that turns things off, activates, so that we don't, like, what it's turning off are our emotions, our ability to feel. And so we're there, like I could be talking to you in a dissociated state, and I'm pretty good at it, so you wouldn't know that it's dissociated. Or I could be just sitting here staring into space. And so during a trauma, there is a point at which both systems are working at the same time. And so I've heard it described as it's like having your foot on the gas pedal to the floor, fight or flight, and your foot on the brake to the floor, freeze. And that as the trauma is evolving, that if the person who is traumatizing us either stops or loses interest, then our sympathetic nervous system is still activated enough that we can run or we can get out of harm's way. But if it looks like this is not going to end, then the parasympathetic will take over and we'll just dissociate, so we don't have to feel what's happening to us. And so that's what like fight or flight is, helping us get out of harm's way. Dissociation is we were unsuccessful, and so at least we're not going to feel when the saber-toothed tiger rips our arm off, because dissociation is the oldest defense system in the body, and it's tied to that vagus nerve. It's actually the dorsal vagus nerve that actually creates that kind of process. And so, yeah, we all have it. It's all our biology. It's interesting. A lot of clients will say, after my trauma, I've sort of lost the ability to know the difference between being safe and feeling safe. And that if I don't ever feel safe, then even the most loving, safe interactions are going to be met with hypervigilance and a need to be in control. So fight or flight is going to be constantly on at that point. And there's physical consequences to that.
Yeah. So when we are children, babies, but even think about toddlers and growing up, preteens to teens, we come in contact with all of these situations in which sometimes we have control, but most of the time we don't. We're kind of at the mercy of our caregivers. I've heard that some trauma researchers will connect things like ADHD, depression, anxiety, OCD to these early situations within our childhood, within our experience with our caretakers, in which we had to come up with a way to survive in the world. And it was through one of those three ways to connect, fight or flight, or freeze or dissociate. And you can start to see how that plays out into the most common mental health conditions that we have, right? So if I am a depressed individual, I am pushing my feelings down. I'm not feeling anything. I am numb. And as you mentioned, it's the same type of coping mechanism that we would use if we are suddenly in the jaws of a saber-toothed tiger and we don't want to feel this pain. And so for those of us who have depression, or think about ADHD, if I'm changing what I'm focusing on so that I cannot focus or don't focus on the present moment, that is a coping skill that helps me survive in the world. Do you adhere to that? Or do you think that mental health conditions like that are not necessarily related or connected to this developmental trauma? Or do you think that they are?
Well, I think it's both and. I mean, I do think there are some biological predispositions to mental illness, but I also think that I think there's a difference between being clinically depressed with major depressive disorder and being situationally depressed by being in a situation that I feel really powerless to change, or I feel hopeless, or those kinds of things. Judith Herman, who wrote probably the best book ever on trauma back in 1991, said that if you're a child in a family and you're dealing with any kind of neglect or abuse of any kind, that as a kid, you don't have the ability to say, well, boy, my parents are really dysfunctional. They're the people that are going to keep us alive. And so the kids will begin to learn that being me is dangerous, and I need to be what people need me to be if I have any chance of surviving. And when you think of that, it's the root of shame-based belief systems and low self-esteem and dysfunctional relationships. So I do think things like depression can be, there's a reason that the only medication that is FDA approved for post-traumatic stress disorder is an antidepressant. And so, I think they do go hand in hand. And to a very large degree, people don't like the term powerless. Like in our world, we use it all the time. The traumas that I've experienced in my life, I was pretty powerless to stop. And if I could have, I would have stopped all of them. And so that idea of, so often I think depression is like the sense of almost hopelessness that I can't. I'm not going to say clinical depression, but feeling depressed, feeling sad, feeling down is often a lack of belief that I'm really in charge of anything.
Yeah. And one of the things you're alluding to and kind of working around is this idea of triggers. And a key part of trauma is the way that it triggers us within everyday life. Could you unpack triggers and how they're connected with trauma?
So trauma memories are remembered unlike any other kind of memory. And so when we're in the middle of a trauma, the left hemisphere of our brain basically turns off. And language lives on the left side of our brain. Analysis, being able to figure things out, happens there. And the right side of our brain is our creative side. It's where all of our sensory organs bring in sensory data. And so what we really remember during a trauma are the sensory inputs that we experienced during the traumatic event. And so when people get triggered, they usually think, wow, something must have happened that was similar to the trauma. And it's some sensory data, maybe the color of the car that hit someone, or the a certain look of a person that was the perpetrator, is what triggers the autonomic nervous system. And it could be virtually anything from taste, smell. I was working with an EMT clinically, and he talked about when he put gas in his truck, that the smell of gasoline would trigger memories of car accidents that he responded to. And I was working with a Vietnam, or not a Vietnam vet, he was in Baghdad. My mind's blank on, geez, what country. And he said that when there was so much, we destroyed the sewage treatment process in the country. And so it always smelled of human waste. He walks into a gas station where the bathroom hasn't been cleaned, and there's an odor that he will have not true flashbacks, but he'll have intrusive thoughts about being back in Baghdad. And so, Iraq, I'm sorry. So, we get triggered by what's going on around us. So our day-to-day experiences can be full of any kind of sensory experience that might remind us of where we were. And so that's how triggers really work. And so a touch, like massage therapists will tell you that they're working on someone and they touch them on the hip or something, and all of a sudden they break into tears, or they get really anxious. And when they ask them what just happened, they'll say, well, I have a history of abuse. And when you touched me, I just had that reaction. So that's how I envision that. That's what I think about with triggers. And again, in the addiction world, what do we talk to clients about all the time? It's all the things that happened to them and the things that they did and these traumatic events in their lives. And so just sitting in a therapy session, having a conversation can trigger all kinds of responses to that. I think it's why young people leave treatment AMA against medical advice, because I don't want to relive all this stuff. And I think why they relapse a lot.
Yeah, we're gonna talk about the coping mechanisms, including addiction, that kind of follow these. But just to summarize your thought, when it comes to these triggers, trauma happens on the right side of our brain, which is also the place where our sensory feelings happen. What we see and smell and touch, that all lives in the same space. And so when there's a traumatic event, those two things become connected. And so we can smell something, or we can see something, or we can feel something that brings us back to that event, takes us to that place, and makes us feel terrible, right? And you mentioned a lot of really good examples. Other examples is, there's people have recommended yoga as a way to be able to find yourself in your breath and to regulate, which is what we're going to be talking about next, and cope with these things. But they go into certain positions and they remind them of sexual trauma, right? Because yoga can be that way. And so they've had to modify the way that they do yoga in order to be able to accommodate these folks who've experienced these types of trauma. And so it's a variety of things that you experience, and it can cause you, to your point, to not want to go out and see the sky or feel the sun or be touched or be able to go into certain spots. And it changes the way that you interact and go throughout the world. And so when you have these situations in which you feel like you cannot connect with the world like you want, that you're having to walk on eggshells, that you're afraid that you're going to be triggered, you start to cope. And you're either going to cope in a positive way that you learned when you were a kid to regulate your own emotions, or you're going to do what's called a maladaptive coping mechanism, something that is a negative thing that over the long term hurts you and doesn't help you. Can you unpack that and relate that to addiction and how addiction plays a role within trauma?
Yeah, I mean, it's interesting. Sometimes even people who have developed really healthy coping prior to the trauma or prior to addiction, when they are in distress, it takes energy, and it's hard to fight, and it's hard to have enough energy to fight in flight, which is what that's the first coping strategy, is to get the heck out of Dodge. But in most cases, the primary coping is to maintain a hypervigilant view, to make sure you've got your head on a swivel and you're looking to see any circumstance that might be similar in some way or triggering those really uncomfortable sensory triggers, and then control. The idea of I'm going to only allow myself to have certain conversations. I'm only going to allow myself to talk to certain people. I'm going to use silence as a control. And so personally, I think it all works best if you have a kind of a recovery coach working with a therapist, because they actually do different things.
Can you give an example of a practical coping skill for trauma that might be taught by a therapist or recovery coach?
So the resourcing from EMDR, just having people stand on one leg, having people go back and forth to begin to reconnect to their body, to reconnect to a sense of self physically. A lot of times when you ask men, what do you feel? They have no idea. The only emotion they allow themselves to feel is anger. And anger is a control behavior. It's a fight or flight behavior. And most people don't walk towards you when you're angry. They walk away from you when you're angry. And that gives you space.
For those of our listeners who aren't familiar with EMDR, EMDR stands for Eye Movement Desensitization and Reprocessing. It's a very effective therapy that uses eye movement and memory recall to help patients process traumatic memories. In the context of EMDR, resourcing refers to the skills and tools your therapist uses to help you stay present during difficult moments, both in and out of therapy. Strategies can include things like mindfulness techniques and physical exercises like the one Dr. Barnes mentioned. And so what you're saying is that therapies like EMDR are designed to get people with trauma in touch with their emotions again, because it's important to understand your emotions to heal from trauma. Am I understanding that right?
I think it's important to educate people on what trauma is. Like the stuff we're talking about right now, the biology of it. If people don't understand it, it's a mystery to them. They feel broken. They feel ill. The DSM used to say that trauma was an event that was beyond the normal experience of any person, and that the trauma response is a perfectly normal response to a perfectly terrifying thing. And so I think we've so pathologized trauma that we've sort of lost that ability that says anyone in that experience has the potential to be traumatized. So one of the things that happened that I found in my research was that perception is way more important than reality, particularly for families. And what that means is, based on 3 generations, they have a belief system about what's normal and what's not normal, what's appropriate, what's not appropriate, how to solve problems based on how my family did it or not how my family did it. And if we can really educate them, then we can help them begin to create new solutions. So new insights allow new solutions. New solutions allow new behaviors. New behaviors allow new relationships. New relationships allow family healing. And so that idea of it starts with new insight. How many therapists tell people like, you should do this or you should do that, and people don't do it. And they don't do it because we haven't done a sufficient job of helping them understand that their perception of the problem may be. That's why I called my book When the Solution Becomes the Problem. Because
explain that a little bit.
Well, it's kind of human nature that how we understand a problem is how we're going to try to solve it. We don't do things that don't make sense to us. And so if I grew up in a family where there was addiction and trauma, and even though it wasn't talked about, keep trying the same things over and over rather than trying new things. And so when the solution, doing the thing that I think is the right thing, the best thing, doesn't work, and we keep trying the same thing over and over again, then the solution becomes the problem that we have to fix. We have to fix perception so we can go into new things. And it also means that if we think about the progression of the illness of addiction, it doesn't start with, emergency room visits. It starts, drinking too much or partying too much or hanging out with friends and getting drunk and, thrown up in dad's car and those kind of things. But eventually it starts moving into really painful and scary things. And that families are constantly adjusting to try to do two things: to keep the family together, but also to keep trying to help this loved one. And over the course of time, as the loved one's addiction progresses, if the family's beliefs stay the same, they'll just keep trying the same things over and over and create a new normal that actually functions better when the person's using.
I see. Yeah. And with all of these coping mechanisms, the danger and the thing that you have to remember is that they're being used because to a certain degree they work. You mentioned anger as a coping mechanism, as a mechanism for control. It's because at some point in their life, somebody did something to them that threatened their identity, their safety, and they got angry and things got better. People stepped back. People looked at them differently. People treated them differently. People didn't mess with them again. And so their brain connected getting angry with being safe. And it's the same thing when it comes to substances. If I'm feeling dysregulated, reminded of things that have happened to me, problems that I've experienced, anxieties and fears that I have, and I use substances as a way to be able to cope with that, it works to a degree.
Sure.
But the thing that you have to remember with any of these coping mechanisms, how can I tell if I'm adapting in a way that's good or bad? Well, if over the long haul, it starts to have a negative impact on your relationships, on your career, on your health, then it's a negative coping mechanism. And we see that over and over and over again. Well, if you're listening and watching and you're saying, okay, this is really great, I appreciate all of these things, I have a much better understanding of trauma, but you're saying, but now what? What do I do? How do I overcome these kinds of things? How do I learn these new self-regulation skills? What are these self-regulation skills? You are going to need to stick around for part 2. We are going to unpack with Dr. Barnes how to overcome trauma. It doesn't matter if it's developmental trauma or an event trauma. Any way that you've learned to be able to adapt in a negative way, we're going to talk about how to learn new, better ways to be able to overcome, unpack, and to process this trauma. But in the meantime, Dr. Barnes, where can people go to learn more about you and all the awesome work that you're doing?
Probably the best place would be to go to my website, which is www.drmikebarnes, DRMIKEBARNES. And it has some information about me. It has some information about our family program and what we're doing and how to get the book and things like that. So, and I also have a YouTube channel, and it's a very weird title, but it's Michael F. Barnes, PhD, MAC, LPC. It's like my credentials. But I've got all kinds of videos about trauma and about family trauma and developmental trauma that would be good adjuncts to what we're talking about.
Absolutely. You're going to find links to all of those in the show notes and in the description box for this podcast or video or however you're watching this. You'll find all of the stuff linked up there. Dr. Mike Barnes, thank you so much for joining us on the show today, and I can't wait to have you back for part 2.
That was my pleasure. Very happy to do it.
Remember, listeners, watchers, this whole trauma thing, it is real, but it is also more common than you think. And with the help of folks like Dr. Barnes, it is also treatable. We'll see you on the next episode. This episode of Treatable was edited by Daniel Lopez. The intro and explanatory sections of the episode were written by Alexandra Kruger. The theme song was created by Sebastian Gonzalez, and the cover art for this episode is created by Joel Daniel. If you got any value from this episode, it would personally mean the world to me if you would leave us a 5-star review wherever you get your podcasts. It helps to spread mental health awareness to more folks, and I read each and every comment that people leave. So tell us what you appreciate about the podcast, and you just might hear us feature it on the next episode. All of my love, and we'll see you on the next one.